Hello, everybody, and welcome to a special edition of the ATS Pulmonary Rehab Assemblies Journal Club. My name's Linzy Houchen-Wolloff. I'm chair of the Assemblies Web Committee and a research physiotherapist from Leicester Hospitals in the UK. Before we introduce today's article and panel, I'd like to ask you all to mute your microphones, as this is a recorded session. When we reach the discussion segments of today, we'd really like to hear from you, preferably in person. So you can do this by raising your hand in the reactions function of the control panel, and we'll then invite you to unmute yourself so you can ask a question or contribute to the discussion. Alternatively, you can put your questions in the chat, or you can post a question on our X page using the handle @PR Assembly, and we'll read this out for you. So today we're discussing the ATS Pulmonary Rehab Clinical Practice Guidelines. This was first published online in the American Journal of Respiratory and Critical Care Medicine in August 2023. So we're revisiting these guidelines 18 months on and discussing strategies to enhance their implementation. So we have Professor Carolyn Rochester from Yale School of Medicine in the US, who will recap the key recommendations from the guidelines. And then Associate Professor Narelle Cox from Monash University in Australia will outline the implementation strategies. We have Dr. Marilyn Moy from the VA Boston Healthcare and Harvard Medical School in the US, who's the chair-elect of our assembly and will be joining our expert panel today. And we also have Dr. Alan Hamilton from the COPD Foundation and McMaster University in Canada, who's a member of our web committee, and he's also joining us for the panel discussion. So without further ado, I'll hand over to Professor Rochester to start the presentations. Thank you.
Thank you, Lindsay. Good afternoon, everyone. My name is Carolyn Rochester, and I note up front that I'm presenting this today on behalf of all of my wonderful colleagues with whom I worked on the development of this document, and also like to give special shout out credit to Dr. Anne Holland, who was not only a co-chair and lead methodologist on our guideline document, but also who contributed several of the slides that I'll be presenting today for your viewing. Just get my little, okay, should be advancing, maybe. Okay, it's not, okay, let me try one other thing. Okay, these are my disclosures. Nothing relevant to today's presentation. So to start out with, why do we need another clinical practice guideline on pulmonary rehabilitation? And there are several reasons for this. The first is that despite being one of the most effective therapies for chronic respiratory diseases, pulmonary rehab remains grossly underutilized and under-resourced. Fewer than 5% of people with COPD who could benefit receive pulmonary rehab, and the numbers are likely even lower for people with non-COPD disorders. There are many health system, patient-related, geographic, and other reasons for underutilization and poor access, which is the topic for a different day. But we recognize this is a very complex problem. The second reason we need another clinical practice guideline is that the evidence base for pulmonary rehab has expanded very substantially in recent years, particularly in regards to not only the role for stable COPD, but also for people with COPD in the post-exacerbation state, as well as for people with other chronic respiratory diseases. And there's a lot of novel work around novel models for delivery of pulmonary rehab. And while we have many existing published excellent clinical practice guidelines about pulmonary rehabilitation from other countries, including the UK, Australia, New Zealand, Canada, and elsewhere, United States healthcare policymakers and payers do not consider the recommendations from non-US based clinical practice guidelines in their policy decisions. And in fact, the last published clinical practice guideline that mentioned pulmonary rehabilitation was part of a COPD clinical practice guideline published in the Annals of Internal Medicine in 2011. So we needed an updated clinical practice guideline, both to improve the clinical practice of pulmonary rehab according to state-of-the-art evidence, as well as to guide and advance healthcare policy and funding and reimbursement for pulmonary rehab. So we set about to develop this project for preparing a clinical practice guideline and pulmonary rehabilitation. The project proposal was in 2018. The project was approved by the ATS finally in the fall of 2019. And we started work just as the pandemic hit. And in fact, the vast majority of work on this project took place during the pandemic. And as such, most of our meetings were virtual meetings rather than the expected in-person meetings. Nevertheless, we proceeded iteratively, and we were able to bring the project to fruition. And I just want to make a couple of brief points about the methodology. Time today precludes a thorough, exhaustive discussion of the methods, but first to say that this clinical practice guideline, as for all ATS clinical practice guidelines, are developed according to strict policies, procedures, and methods of the ATS for clinical practice guidelines. Secondly, we had a multidisciplinary panel and a patient representative. We had 4 co-chairs and 4 methodologists who are both starred, and the numerical signals indicate who those people were. We had people from respiratory specialty medicine, nursing, cardiology, respiratory therapy, and a variety of other physical therapy and a variety of other disciplines. And we had also a patient representative. We set about to decide on specific PICO questions: patient, population, intervention, comparator, and outcome PICO questions that were chosen to highlight key aspects and outcomes of pulmonary rehab, which we felt had the greatest potential to impact clinical practice, public policy, and reimbursement for pulmonary rehabilitation. We could only choose 6, and therefore we weren't able to exhaustively cover all aspects of pulmonary rehabilitation. But for each of those PICO questions, we used a modified Delphi approach to decide on what one critical outcome of each of those questions would be, and several, up to 5 other important outcomes. And we used systematic reviews and randomized controlled trials only for our data analysis. And where the existing systematic reviews either didn't exist or were older than published in February 2022, we did further literature search and updated literature review. And ultimately, grading of recommendations, assessment, development, and evaluation approach, or the grade approach, was used to appraise the quality of evidence and formulate and grade the recommendations for the document. So I'm going to present to you very quickly, run through what our 6 PICO questions were and what the findings were and the recommendations made. So our first question, PICO 1, was, should adults with stable COPD undertake pulmonary rehabilitation? And here our patient population was those with stable COPD, and we had compared people who either did versus did not partake in pulmonary rehabilitation, non-participants receiving usual care. And for this question, we reviewed and analyzed 82 randomized controlled trials with nearly 5,000 participants. There was a range of FEV1 of the participants from 26% all the way up to 75% of predicted, so mild COPD all the way to very severe. Our pre-specified critical outcome was the 6-minute walk test distance, and other important outcomes were dyspnea measured by the CRQ, total St. George's Respiratory Questionnaire, adverse events, and hospitalizations. And as you can see, we saw significant effect of pulmonary rehabilitation in improving 6-minute walk distance, dyspnea, quality of life, without any increased adverse events. There was no particular effect in this group on hospitalizations. All of the benefits reached or exceeded the minimal clinically important difference for these parameters. And so our first recommendation was that for adults with stable COPD, we recommend participation in pulmonary rehabilitation. And this was a strong recommendation with moderate quality evidence. We placed high value on the improvements in exercise capacity, dyspnea, and health-related quality of life. Patients value the benefits of pulmonary rehabilitation. There were no significant adverse events, and we placed lower value on the travel burden, cost, and inconvenience in making our recommendation. For our second PICO question, we asked, should adults with COPD undertake pulmonary rehabilitation following hospitalization for an exacerbation? And here our patient population were people who had been hospitalized with a COPD exacerbation and who either had or had not then undertaken pulmonary rehabilitation, the majority of trials looking at within a 3-week time period of the discharge from the hospital. And here we had 17 randomized controlled trials with 1,724 participants. The mean FEV1 ranged again from 31% to 57% of predicted. Our pre-specified critical outcome was hospital readmission in this case, and here you can see our other selected important outcomes. Here again, we saw significant benefits of participation in pulmonary rehabilitation on reducing the risk of hospital readmissions with an odds ratio of 0.48. And we saw significant benefits in terms of 6-minute walk distance, exercise tolerance, the St. George's Respiratory Questionnaire measure of health-related quality of life. We didn't see a significant change in dyspnea in this particular analysis or mortality, but no significant adverse events were reported. So our recommendation regarding this PICO question was for adults with COPD. We recommend participation in pulmonary rehab following hospitalization for an exacerbation. Again, this was a strong recommendation with moderate quality evidence. We placed a high value on reducing hospital admissions and improving exercise capacity and quality of life. Patients value staying out of the hospital. We did not see any evidence of significant adverse events, and we placed a lower value of burden on attendance. This is something we can discuss more if there's time going forward. The third question, should adults with interstitial lung disease undertake pulmonary rehabilitation? And here our patient population was any patient with interstitial lung disease of any form, and we included those with versus without idiopathic pulmonary fibrosis. And the comparator was no pulmonary rehabilitation. Here we found and analyzed 21 randomized controlled trials with 909 participants. The mean forced vital capacity ranged 55 to 86% of predicted. And again, in this analysis, we found that pulmonary rehab for this patient population conferred significant gains in 6-minute walk distance, health-related quality of life, dyspnea as assessed by the MRC dyspnea score, and no significant adverse events were noted. And again, these reached or exceeded clinically important differences. There was no significant effect seen in regards to hospitalization or mortality. For our third recommendation, therefore, for adults with interstitial lung disease, we recommend participation in pulmonary rehab. Again, a strong recommendation based on moderate quality evidence. We placed a high value on improving exercise capacity, dyspnea, and quality of life. We feel these outcomes are likely very important to patients. There were no significant adverse events, and we placed a lower value on the burden of travel, cost, and inconvenience. For question number 4, we addressed, should adults with pulmonary hypertension undertake pulmonary rehabilitation? And here again, it was participation in pulmonary rehabilitation versus no participation amongst a mixed population of people with pulmonary hypertension, although a majority of them had pulmonary artery hypertension or precapillary pulmonary hypertension. Here we analyzed 14 randomized controlled trials with 571 participants. The mean pulmonary artery pressure range of the participants was from 36 to 59 millimeters of mercury. So moderate to significant pulmonary hypertension in this group. And here we saw significant benefits in regards to 6-minute walk test distance, health-related quality of life as assessed by the SF36, physical component score, and no significant adverse events. Interestingly, none of the studies analyzed had data included in regards to whether or the pulmonary rehab changed the severity of dyspnea. And some analyzed functional class, but the effect size was not all that high. So no deaths, no significant adverse events. There were scattered occasional adverse events reported, and we can discuss that further as to the specifics. But for our recommendation number 4, for adults with pulmonary hypertension, we suggest participation in pulmonary rehabilitation. However, this was a conditional recommendation based on existing low-quality evidence. Because at this time, we only have low-quality evidence for improvements in exercise capacity and quality of life. But we do think these outcomes are likely important to patients. There were no significant adverse events, provided that there was a supervised program where staff have expertise in pulmonary hypertension. And it's clear that patients should be stabilized on optimized medical therapy before undertaking pulmonary rehab. Now, we recognize as a group that there are many other respiratory disorders for which pulmonary rehab can be helpful, but we could not cover all of them within one document. And we felt it was important to analyze other aspects, such as novel models, including telerehabilitation, and also looking at resource utilization, the issue of whether maintenance pulmonary rehab was effective. So our 5th question was, should adults with chronic respiratory disease undertake telerehabilitation? And here, as opposed to no rehabilitation, our comparator was people undertaking telerehabilitation versus those who undertook center-based traditional outpatient pulmonary rehabilitation. And we had 5 randomized trials, 2 controlled clinical trials, nearly 1,200 participants. And here what we saw was equivalent benefits with regards to 6-minute walk, health-related quality of life, and dyspnea assessed by the CRQ questionnaire for both telerehabilitation and center-based rehabilitation, with actually an increased odds ratio of program completion for the telerehabilitation as compared to center-based rehabilitation. No significant difference in hospitalization or adverse events. So our recommendation based on this existing data was that for adults with stable chronic respiratory disease, we recommend offering the choice of center-based pulmonary rehab or telerehabilitation. And this also was a strong recommendation with moderate quality evidence. We noted similar gains in exercise capacity, health-related quality of life, and dyspnea. Patients valued the convenience and flexibility of telerehabilitation, but we felt strongly that certainly not all outcomes of potential relevance have been assessed to date, number one. Number two, we don't believe this is a replacement for center-based programs, but an alternate option for, which may be particularly useful for people in rural areas or who otherwise cannot access center-based programs. The optimal telerehabilitation model is not clear. And a key caveat to our data here is that more than 99% of the participants in the studies analyzed had COPD. Lastly, we had a question, should adults with chronic respiratory disease undertake maintenance pulmonary rehabilitation? And here we analyzed 21 randomized controlled trials with nearly 1,800 participants with mild to very severe COPD. And what we found here was there were no significant adverse events, but we did not find any significant advantages of people participating in a maintenance program of various forms that were analyzed in various studies, but no particular gains, extra gains above the initial participation in pulmonary rehabilitation after maintenance pulmonary rehabilitation in regard to 6-minute walk test distance, CRQ dyspnea, St. George's Respiratory Questionnaire, or hospitalizations. So here, although every single one of us on the panel, and I believe most in the field of pulmonary rehab would recommend that it's important that ongoing regular exercise be undertaken after completion of pulmonary rehabilitation, based on the existing data of randomized controlled trials, we are not able to formally recommend maintenance programs as superior to center-based pulmonary rehabilitation, for example, with self-continued exercise. And therefore, we suggest either supervised maintenance pulmonary rehab or usual care, again, with the caveat, hopefully they continue to exercise after initial pulmonary rehabilitation. This, again, was a conditional recommendation with low quality evidence. We know that people with COPD and other respiratory diseases value ongoing supervised exercise and support. The choice depends on needs, capabilities, preferences, and local access. We don't feel that absence of evidence is evidence of absence. We think that we need more work in this area. So as I said, there clearly are other disorders for which pulmonary rehab is beneficial. We just simply couldn't tackle them all in this document. But our conclusions overall were there's an important role for pulmonary rehab and evidence-based healthcare for people with COPD, ILD, and pulmonary hypertension. Funding should be a priority. We need to foster access to pulmonary rehab. It's important to enhance the number of healthcare professionals trained in the discipline of pulmonary rehab, both to confer pulmonary rehab to people who need it, as well as to continue forward research in the field. We need to implement newer models of pulmonary rehab while maintaining the key expected benefits and assuring quality of those interventions. We need collaboration between healthcare professionals, patients, caregivers, payers, administrators, and policymakers in order to move the field forward. And we need implementation of the clinical practice guidelines. It's challenging but key, and that's the subject of our further discussion today. Lastly, I'll just say that we did have recommendations in the document that you can go back to and refer if you haven't seen them for further research needs in pulmonary rehab in a wide variety of areas. And implementation of the clinical practice guidelines is very important in regards to moving these research fields forward as well, because it will help to answer some of the remaining questions. And I'd like to thank you for your attention. I'd like to thank all my colleagues from the guideline panel, without whom this would not be possible. Likewise, the ATS staff, Dr. Kevin Wilson, and the librarian for University of Sydney, who helped us with our literature searches, and certainly also Grace Ann Dorney-Koppel, our patient representative, whose insights and input were, as always, invaluable. Thank you very much.
Thank you very much, Carly. That was a really thorough recap and brought us all back up to speed. So thank you very much. I'm going to hand over to Narelle now. Sort of the main focus for this evening is about how, as a collective, we can support the implementation of this work. So Narelle is going to take us through the implementation strategies.
Thank you very much, Lindsay. I'm just going to find my slides for you. Excellent. I think we're good to go. So thanks very much, Lindsay, and to the web committee for inviting me along to speak. So this is a bit of an update on where we've managed to get to with the implementation strategies as far as the guideline is concerned. Okay, so I have no disclosures to report, and this morning I'm speaking to you from the lands of the Bunurong and Wurundjeri clans of the Eastern Kulin Nation here in Melbourne, and I pay my respects to their elders past and present. So as Carly has already highlighted for us, the reasons behind why we needed to undertake a clinical practice guideline. But just because we now obviously have that guideline doesn't automatically mean that the recommendations in it will be implemented into practice. And one of the key challenges to implementation of recommendations is obviously adherence to guidelines, and the available literature suggests that this can often be as low as 5%. So all of the effort that goes into creating the evidence and then analysing it and putting it together frequently does not actually result in change. So when it comes to the implementation of clinical practice guidelines, and it's worth noting that whilst we're sort of talking in the context of implementation, a lot of the strategies that we're probably talking about today are actually dissemination. But for the sake of the argument, we'll stick with the terminology of implementation. And certainly there's no one best strategy to support guideline implementation, but there's some evidence that simple strategies are better than more complex interventions. But whatever these interventions are, they require planning and strategizing and consultation, partnership, a plan, and in particular, a group of or a workforce to be able to make it move forward. So at the time of the guideline publication, and in alignment with the previous ATS ERS statement on pulmonary rehabilitation, it was determined that the three key targets, if you like, for implementation and dissemination strategies were healthcare professionals, patients, and policy or advocacy groups, and overlapping with payers. And of course, it's worth remembering that these three groups are not mutually exclusive. So within the guidelines themselves, each of the PICO questions contained implementation considerations. So for PICO questions 1 and 2, this was particularly around education of healthcare professionals with respect to the benefits of pulmonary rehabilitation and the need and processes for referral. For PICO 3, for people with ILD, it was a practical consideration in terms of ensuring that there was oxygen available in the environment in which people were undertaking their exercise training. For PICO 4, relating to pulmonary hypertension, that people were on stable, optimised medical management prior to commencing rehabilitation. For PICO 5, telerehabilitation, that such programs needed to follow the procedures that are outlined and the components that identify them as being pulmonary rehabilitation. And for maintenance rehabilitation, PICO 6, that the choice of a maintenance pulmonary rehabilitation or unsupervised exercise training needed to be guided by a patient's needs, capabilities and preferences, but also what was available to them. So our question at that time was, well, how do we then make this information available to these key targets? And so this is some slides that we presented at the ATS conference in 2023 associated with the launch of the clinical practice guidelines, with a bit of an update of where we've got to. So for our first key target area of healthcare professionals, we have produced 3 publications, and I'll comment on those in a moment. There was an ATS press release in August 2023 to coincide with the publication. As I've mentioned, we had a clinical symposia at the conference in May of 2023. We had a journal club in March of 2024, which covered the clinical practice guidelines in more detail, as Carly has already presented. And throughout the period of time related to the conference and the launch and the publication and all of these other activities, we've had continued flagging of the practice guidelines on social media. And clearly this slide was made in a time before, when Twitter still existed and before X became a thing. So this slide just sort of highlights in addition to the publication of the guideline, we have published the summary for clinicians in Annals of ATS. The systematic review relating to PICO 2 was also published in Thorax in 2024 as well. The ATS suite of implementation strategies, which includes a YouTube video, but also what they describe as a flip book. So there's images of that there, and that's available for download. We've also undertaken a series of posts on the ATS Doc Matter channel relating to the PICO questions to try to generate discussion and awareness. But I guess a key factor with all of these strategies is how can we be sure that we're getting any reach beyond ATS members, respiratory specialties, or in particular, the people that are already involved with pulmonary rehabilitation anyway, and are probably the people that were already familiar with the existence of the guideline. When we talked about our key target of healthcare professionals, one of the factors associated with this was that concept of how do we make the guidelines known to people that are outside the pulmonary rehab assembly and the wider ATS. And this was particularly highlighted as being important when we consider that in the US, 80% of people with COPD are managed exclusively by a primary care physician. We flagged whether there was need or an appropriate pathway to consider was to look at quality standards, particularly relating to guideline uptake. And we flagged there similar strategies that have been undertaken in other jurisdictions, in particular the UK audit relating to pulmonary rehabilitation and quality standards. And we highlighted an assortment of other possible strategies and organisations that we might want to consider involvement with. When we think about our key target area of patients, we have updated in line with the guideline, the pulmonary rehabilitation ATS patient handout, and that is now available on the ATS website. But we posed the question as to how best we could engage with advocacy groups and then by extension patients, and what was the best way in particular to reach underserved groups. So the people that often don't end up getting to pulmonary rehab at all, and often are the people that haven't been represented in the clinical trials to date. When it came to our key target group of policy and advocacy groups, we noted that we had the benefit of the ATS press release and potentially our social media strategies, and we identified an assortment of clinical partners that might be people or groups worth associating these strategies with. But the key note here is, of course, this list is obviously not extensive. These last 3 slides lead us to my next point, which is probably the progress that we've made with trying to potentially address some of these. And this is quite hot off the press. And if you like, it is a potential step forward. So we have approval just recently from the ATS to form a collaborative working group between pulmonary rehab, assembly, relevant personnel, ATS personnel, and the COPD Foundation. And this is with the view to being able to perhaps develop a implementation or dissemination plan that we can make use of the logistical and practical support of the COPD Foundation, given their size and reach across both to patients, but also from an advocacy perspective across the US. So as I've said, we've got preliminary approval from the ATS to bring together a working group. Once we have a working group and an initial work plan, we then need to seek formal approval for this to move forward. So like I say, this is a preliminary flag of what might be able to happen, but there is no guarantee, I guess, yet that this will be a strict pathway forward. We have sent out initial working group invitations, and certainly the hope is that if we're able to proceed down this pathway with the COPD Foundation, that this might be able to serve as a model for engagement with other patient organisations to be able to spread the word further about the clinical practice guidelines. But I guess all of that, in summary, 18 months on, is to go, how do we actually still reach beyond the core group of people that we already are preaching to? And are there other, ideally innovative activities that we could or should consider that we haven't got to yet? But I think a lot of this then boils back to who is going to drive these strategies forward. And as Carly highlighted, a key driver for this guideline was to be able to make inroads within the US space, particularly with the challenges there associated with reimbursement. And so how do we drive this in that space with people that are going to be appropriate for the US audience and have the gravitas to be listened to in that space? So who are the best people to be involved and who will help with the legwork that's required? How will we even know if any of these strategies have been successful? And at the end of the day, I think our goal for all of us is to be able to support more people to be able to access pulmonary rehabilitation. How will we know whether we've actually achieved this on the back of these guidelines? And is that even possible? So Carly sort of threw down the challenge with her slide deck, which was a picture from her local area of icy snowy trees. So I decided I needed to take up the challenge and give you a bit of summer beachside action. And of course, we'll be happy to take questions when we get to that part of the proceedings.
Thanks, Narelle. I think that's lined up really nicely for Marilyn to sort of start the discussion and hopefully get some audience interaction as well, which we want to gather your ideas too. So I'll hand over to Marilyn.
I would just like to say I'd rather be on the sunny beach than in the freezing trees.
Although we've just been through a 4-day heat wave, so you might think different about that.
Well, oh, here we go. I think it just needed some time to remember. Okay. Can you see my slides?
Yeah, perfect. Thank you.
Okay, great. Yeah, so thank you so much, Carly and Narelle, for that discussion, that starting off on us on this discussion. So I just have 3 slides, and so this should be quick, and I just wanted to get us started on a discussion with the audience, because I know for myself, I'm very eager to hear what other people think about how we can implement and increase the access to pulmonary rehab. So these are by the different PICO questions, and Linzy asked me to join and to try to give my input as the upcoming chair of the assembly. And so these are quite bread and butter, kind of on the front lines topics and points that I wanted to bring forth. So in terms of, adults with stable COPD being referred to pulmonary rehab, I'll try to talk about things that weren't already mentioned in Narelle's talk, but I do believe that we need to build back our center-based programs, particularly here in the US. And I'm still trying to get to know how pulmonary rehab programs are implemented outside of the US as part of my position, and really excited about doing that. But I know in the US, especially here in the VA, for example, where we have the data to look at, we know that center-based programs have not come back since the COVID-19 pandemic, whether it's because resources have been reallocated to other practices, or for whatever reason, or cost reasons, we have seen a significant drop in the number of center-based programs. And certainly in the VA, when we're referring out to community care, we're also seeing that even the other non-VA pulmonary rehab centers outside of the VA in the US are also closing down. So we do need to put, we can't refer patients to pulmonary rehab if pulmonary rehab doesn't exist. So they need to be built back. You need to leverage our positions, wherever they might be, to try to get them into blueprints of new buildings, of hospitals, or locations, so that the pulmonary rehab is actually there that they're going to be built into the blueprints. It's already been mentioned, we do need to train more pulm rehab staff so that they can work in these centers. We need to build a pipeline. And then, as you know, we had heard at the last webinar from Martine, that marketing, I totally agree, is where I think we need to put a lot of more effort. And certainly, as Narelle said, you know, who is going to do this with us and for us, because it does take a lot of time and effort and money. But I think some low-hanging fruit is even our own hospital websites, to make it easier there for our patients as well as the general public to be able to look under pulmonary and then see right there is pulmonary rehab, and then understand what it's about and how it's available. You know, one of my dreams is to have a patient come to me and say, I saw a commercial about pulmonary rehab. Like, I want to do that. Like, how do I get there, you know, as a patient in my clinic? You know, as opposed to similarly to asking about, you know, I saw a commercial about Dupixent. How can I get that? I need that. You know, I feel like that's where we want to be with pulmonary rehab, if that's possible. You know, even in waiting rooms, as you know, we talked about trying to get to our primary care providers, and can we actually play videos? You know, learning from the Big Baton Pass, which was a huge success. I think the videos are extremely helpful. They say, you know, in pictures what we can't say in 1,000 million words. And this gets to my next point about being able to represent the patient's perspective. And so, you know, we had a lot of patient interviews represented on those videos, and for patients to see themselves represented there, to hear from their own, you know, to their own fellow patient, you know, patients, that, you know, they too were really worried or fearful of starting exercise. How could I even do this, walk on a treadmill when I'm on oxygen? But hear from another patient who has just completed pulm rehab say, you know, just do it. I was there in the same spot, and it's definitely safe and it's worth it. These are the benefits. I was so surprised by what our patients said in terms of the benefits. They went on to talk about how their blood pressure was better controlled, how their sleep was better, that their mental health was better because of the sleep and the exercise. So they're already, you know, they're reaping benefits that aren't even common ones that we say, you know, in terms of talking to our patients and talking about pulm rehab, and trying to leverage these videos that are already developed, and how can we, you know, get them to more people to see, because I've shown them to a lot of people here at the VA Boston, for example, and they're like, oh, that's what pulm rehab is all about. And so even though we've tried so hard in the past with words and documents, the videos have really been helpful. With regards to education of our healthcare providers, particularly our primary care physicians, I would say, you know, getting ourselves out there to give the medical grand rounds, to go to a primary care, you know, seminar or lunchtime conference, you know, whether it's us or, you know, our colleagues. I think that's really helpful for them, again, to understand, show our videos, trying to get past this preaching to the choir concept that Narelle had referenced, that we want to get into the general medicine journals, you know, or even, yeah, mainly and then to make it make the important point that it's okay to refer the sickest patients, because we've found, and there are data out there to show that they may be the ones who benefit the most from pulmonary rehab. But I think the referring providers are always concerned that they're too sick to participate in pulm rehab, and so I'm not even going to refer them. And to be able to educate our colleagues to say that you should just go ahead and refer them, and then we can make that assessment, is really important. And then, moving on to the issue of adults with COPD after hospitalization, you know, after an exacerbation, I would say trying to include pulm rehab in the discharge bundles, because, you know, and here in the US, we're relying on residents and trainees to do those discharge orders, and they have no idea what pulmonary rehab is all about. And so being able to educate them at, again, grand rounds, but also making it easier for them not to have to search for the pulmonary rehab tab, if it's all in there with, you know, the oxygen or the referral back to pulmonary clinic, that would be really useful. And then certainly if we're not able to offer the pulm rehab at the time of discharge, that we also have this set standard where we're offering the pulm rehab at the first clinic visit after the hospitalization, whether that's in the pulmonary clinic or in primary care. And then there are more data coming out on the cost effectiveness of pulmonary rehabilitation. So we really want to emphasize education on that aspect, because sadly, I do believe that that's what drives a lot of our care, and what gets implemented or not is about the cost. And now we have more and more evidence, both internationally, from Narelle's group, as well as domestically here in the U.S. From Chris Mosier and his work, that there are cost effectiveness data to support pulmonary rehabilitation. I don't have a lot to say about this number 3 and 4 for patients with interstitial lung disease. I do think that the patients and the providers need to be comfortable with the fact that these are people who are on supplemental oxygen and can still safely exercise. And this does come from experience, which is why I do believe that center-based pulm rehab programs need to stay with us and persist, because that is where the training happens, and where we as healthcare providers gain that confidence, knowing how hard we can push our patients and who can be safe exercising, and knowing that even though they're on 6 liters of supplemental oxygen, that they're going to be fine. Having the patient testimonials also on the videos, for example, or even having patient buddies. It could be really helpful in terms of knowing that they have the same disease that you do, and are on oxygen and can safely exercise. In terms of pulmonary hypertension, I think we do need more studies and data on that to move forward. I did want to get to number 5, because I do have a lot to say here. I feel like this is actually the guideline that has been most rigorously adopted out there, particularly here in the US, and not in a way that we think has been constructive and helpful. So, we found that a lot of, that there are more and more standalone commercial entities that are offering what they are saying is pulmonary rehab and delivering it remotely. But in fact, when you look a little more closely, they are not offering pulm rehab the way that we are defining it, in terms of having an exercise prescriptions, having a clear plan for exercise progression, and having the initial and exit evaluations to assess for outcomes. And so what we're finding is that there is a lot of different, as Dr. Linda Nietzsche puts it, a word salad out there, where we need to harmonize some of these terminologies. So we've seen telerehabilitation, which we used in the clinical practice guidelines. There's the pulmonary telerehabilitation, which was used in the Cochrane review that was led by Narelle. We have telepulm rehab, we have virtual pulm rehab, home-based pulm rehab, and then we have this whole conglomerate of technology-mediated physical activity interventions that can be, self-management programs or health coaching programs, which I would say does not offer pulmonary rehab. We know the GOLD guidelines, we know the GINA guidelines for asthma. The GOLD guidelines for COPD both put physical activity and pulmonary rehab in 2 very separate buckets. They're 2 very separate treatments for the non-pharmacologic treatment of COPD and or asthma. And so we want to differentiate this. And I would say that, we want to make sure that that programs are offering pulmonary rehab. And so for tele-rehab, I feel like we have to do some policing and to try to make sure that the uptake of this guideline, the implementation of it is rigorous. In terms of quality metrics, and I do strongly believe that the vigorous models need to be built out from center-based programs where the expertise lies. We do need to collaborate with these standalone entities. We're definitely trying to embrace, and we want to embrace the innovation and trying to get the pulmonary rehabilitation to patients in rural areas and who are underserved, but we don't want to do that at the expense of, watering down what is pulmonary rehabilitation. If it's a physical activity promotion intervention, that's totally fine. That's definitely better than nothing, but we want to call these things what they really are and what they are delivering, both for reimbursement issues, particularly here in the US, but also so that the providers who are prescribing it and the patients who are receiving the treatment know what they're getting. And then I would encourage that all of us as reviewers on papers that are publishing new evidence on telerehabilitation, that we are making sure that the interventions that are being described maintain fidelity to center-based pulm rehab, and that we're ensuring quality. And then this last, number 6, about maintenance pulm rehab. Again, I really think that the center-based programs are needed here to build this out, and that where virtual pulm rehab could actually have a big role is to be able to extend the center-based programs here and be able to deliver maintenance pulm rehab, but we definitely need more research and data on that. So with that, I'm going to end and raise this open this up for discussion. I wanted to share my slide of this wombat, which I was able to visit in Australia when I was there this past summer. So wanting to bridge the geographic divide here between our friends and colleagues in Australia and we here in the US. So I'll stop sharing there and turn it over to either Alan or Linzy. But we would really love to hear from the audience what your thoughts are about how you're implementing at your own sites and what you think about the clinical practice guidelines.
Thanks, Marilyn. Lots of food for thought there. I'm going to start with Tanya. She's happy to ask her question live, so I'll hand over to you.
Hi, everyone. I just posted there. You can read it too, but I'm just wondering, because to me, it seems the way the PICO question were worded, it's, whether or not we think pulmonary rehab should be recommended for this, for COPD, ILD, and so on. So it's more about the referral there. So we recommend, so we want people to refer people to patients to pulmonary rehab. The other thing is about having specific guidelines on how to deliver pulmonary rehab. So considering that this was focused on whether or not they should be participating in pulmonary rehab, in my opinion, I think the most important people that we should be working on, at least here in Canada, I think it's like this, is the primary care professionals. So I'm wondering if you guys have collaborated with them. I think in one of the slides, I don't know if it was Narelle that had the Family Physician Association or something like this. Here in Canada, there is a network of family physicians who are interested in respiratory disease. It's the Family Physician Airways Group of Canada, and there are more than 2,000 physicians, primary care physicians who are interested in respiratory disease. And I think that could be an important network, but that is in Canada. So I don't know if in the US you have something similar that you could try to collaborate with.
I agree with you, Tanya. That's it's a really important patient, healthcare professional group to work directly with. It's a little hard to get connected in the US. It's a little bit diffuse, and we've struggled a little bit about how best to do that. But I think ongoing initiatives and efforts in that direction are very important, because as was also mentioned earlier today, the majority of people with COPD are seen within the primary care setting. Mm-hmm. One of the things that we've done at our institution to make inroads into this is we have a couple of COPD focused care pathways. One is an inpatient care pathway, but we built one also as an outpatient care pathway for primary care physicians. And we embedded referrals to pulmonary rehabilitation within that. So I think, getting people to use pathways is another thing, but as they become more familiar, that is one way that we can reach out to our primary care partners and raise awareness of pulmonary rehab.
Narelle?
I was just going to add, I absolutely agree with you, Tanya, and I think that engaging with primary healthcare professionals is not just a challenge for the US, but probably everywhere. I guess I would like to throw back to the people that are in this group today and go, engaging, if we can find the connection, that's wonderful. But what suggestions do people have in terms of then what could be that next step? Because making the connection is one thing, but how then, is it just a case of, well, we try to publish a summary in one of their journals? Like what, I guess part of my challenge with this whole concept around implementation is what then is the thing that comes next? And I think we're hopeful that perhaps our hopeful collaboration with the COPD Foundation might give us an opportunity to have a bit of a framework that we could then apply to some of those other sectors. But, I think we can come up with the list of groups that we think would be ideal to target. I think we probably need to have a bit of an idea then that we take to them to open the discussion about how those groups then would like to move forward. Alan, I don't know if you have any additional thoughts to add on that.
Yeah, thanks, Narelle. Yeah, I mean, I'm excited about the possibilities that we have, and it's early days. But one of the things for me, I've been involved with the Pulmonary Rehab Assembly for a number of years now, but more recently been involved about the last 3 years with the COPD Foundation. And one of the things, I think one of the slides said about preaching to the choir, and I think what we have the opportunity with this type of collaboration is actually bringing in others that maybe are not so familiar with pulmonary rehab, and actually engage in that discussion to really look to see what other opportunities are there. And I think the idea of going through the patients, I thought was a really nice idea. And I think, Narelle, when you and I met with the ATS staff, I think it was Judy Korn, it really novel idea of what if the patients, or what if we educate the patients and have the patients actually going to the family physicians and actually asking the question. So maybe having the patients actually initiate the discussion rather than waiting for the physicians to initiate the discussion.
Yeah, and I think it comes back to one of your earlier points, Narelle, where, talking about that difference between dissemination. We can give out the information and it may be we've not hit all the right target groups thus far, but then it's how do we make sure that the recommendations are then implemented and what do the metrics look like around that? I'd like to bring in Mick Steiner, who's got a related point on this. Thanks, Mick.
Hi, everybody. Thanks very much for lovely talks. It was stimulating. So, I mean, I'm impressed with the amount of effort that's gone in, but I think we have to also recognise that the history of guideline development across the piece in medicine is that they don't often result in themselves in major change in practice. It's a one step. Other things have to happen, and you're doing the right thing about thinking about other things. To me, we've got to understand. We understand the accountability of the key partners relevant to pulmonary rehab, and we're a bit vulnerable to the need for colleagues to refer patients to pulmonary rehab and for policymakers and commissioners to support rehabilitation programs. So we've got to understand the accountability of those constituencies and what will incentivize those groups to refer to pulmonary rehabilitation support programs, and how that accountability is measured. Because if physicians are referring are accountable for the quality of their COPD care, then they will refer for pulmonary rehabilitation because it's the most effective treatment. And commissioners will provide programs because it's highly cost effective. We can demonstrate that, and we've shown that nicely in the presentations today, but I'm not sure how well we are demonstrating it to those constituencies, and that seems to me to be the challenge. Are we successfully influencing family physicians, as we've talked about, secondary care physicians who are going to have other things that they're interested in, biologic therapies, for example, for COPD. They'll be occupying their thoughts. Probably an awful lot less effective and less cost effective than pulmonary rehabilitation, but that doesn't necessarily mean that they're going to take second place to pulmonary rehab. So I think we have to think about that, and we've had experiences in the UK, which is admittedly a highly accountable system because it's publicly funded, and therefore the government wants to see that the money it's spending provides high quality care, and therefore it sets high standards and it audits against those standards. So that's the history of how this is done in the UK, and we do have well provided pulmonary rehabilitation and imperfect uptake, but it's not too bad. It's better than many areas. And if you don't have that kind of accountability, it's much more difficult. But unless we incentivize and make those other constituencies accountable, I think it will be very difficult.
Yeah, good points, Mick. Thank you. Carly, did you want to come back?
Thanks, Mick. Just to the point you just made about accountability and reaching the policymakers and payers, but also wanted to first echo, I think it's essential that we have our patient base, not only COPD, but our broader patient base, be knowledgeable to actionably request pulmonary rehabilitation and advocate for themselves to get it. That was actually one of the actionable items we had put in the policy statement on enhancing implementation and utilization of pulmonary rehab back in the 2015 document. But I just wanted to speak to the issue of health system and payer advocacy and moving that needle forward in the United States. We've been working within the ATS to develop a quality metric. You know, we have national quality metrics in the US, things such as providing flu vaccines to people who are in the proper age range and patient group, and providing bronchodilators to people with COPD, and checking hemoglobin A1Cs on people with diabetes, things like that. And we've been working to develop a quality metric for healthcare professionals to refer suitable patients with COPD to pulmonary rehabilitation as a national quality metric that ultimately, if it were to be adopted by Medicare, Medicaid, Center for Medicare Services, would require that people refer suitable patients or potentially be linked to payments. Part of the problem we're facing with that is it's a tremendous moving target in terms of the different types of Medicare, Advantage plans and different groups that are covering the insurance and covering pulmonary rehab. We do have a working group within ATS. It's also a multi-society working group on reimbursement for pulmonary rehab that's working on this too. And the other big problem we're running into is, frankly, is the cost of developing one of these metrics. It's one thing to put the measure in place and to say this is what should happen, but then it has to get validity tested and reliability tested, and there's a whole bunch of steps that it has to go through before it will even get looked at for potential adoption by Medicare. And so and the private insurers tend to follow along suit with whatever the Medicare and Medicaid follow. So we're working on it, but we don't have the sort of national audit system that you have, and so it's a little bit more challenging for us.
Yeah. Thanks. Right, I'm conscious of time, so just going to wrap up. We always run out of time in these webinars, so if you do want to carry on with the conversation, we've got Doc Matter. You'll find the PICO questions that were discussed in depth last year, and you can also continue the discussion around this webinar. So hopefully you've got a Doc Matter account, but if not, that is the link for you. So I'll just finish off by obviously thanking Carly, Narelle, Marilyn and Alan for their contributions today, and thank you to the audience for listening and interacting with this session. Thanks also to Samantha Carpin at the ATS for all of her help with setting up today's webinar. The recording of this webinar will be available on our website in the next few days if you want to signpost any of your colleagues to this, and we'll announce our next journal club in due course. Hope to see you soon. Thanks.